students, very good evening to all of you. So we are continuing with our DNB paper discussion. And last few weeks we did paper one and paper two. And this week we'll do paper three and next week we'll do paper four. Now, this DNB paper was one of the easier papers as you will see. Not very difficult questions. Like many of the questions you could have answered even without much preparation. But don't get fooled by this paper. Paper 4, which also I'm preparing, which I will be discussing next week, is much trickier. So don't see this paper and be like, oh, such an easy exam to clear. This is relatively easy. In fact, I don't think it will take me much time to discuss this, but watch out for the next week's paper. Right. So let us begin with solving. And you realize that a lot of questions were standard questions, easy level questions. Some questions were a little tough, which I will show you how to handle. But overall, a very manageable paper. Right. So let's start with the first topic. That is the first question. And this was a straight up question. Briefly discuss the clinical features, investigations, and treatment of GERD. So this is not really a DNB or an MS level question. This is a more basic level question you can write comfortably. So I will tell you how do you make it a little different from what a normal even an MBBS student would write. How is your answer going to be different? So they have asked you precise things. Clinical features, investigations, so 3 marks, and treatment for 4 marks. So when you write clinical features, don't just write retrosternal burning, epigastric pain, regurgitation and all. Also write what will trigger the GERD. So we know there are triggers which lead to what is called as TLOSR, transient lower esophageal sphincter relaxation. So you want to mention that as well so that it gives you a little edge. It should not sound like a very MBBS student kind of an answer. So what are the triggers? Smoking, spirits, spices, something in diet, fatty foods, caffeine, chocolate, anything that increases the intra-abdominal pressure will worsen reflux, right? So these are some of the triggers, and typically it comes as a triad, the clinical features. So you get retrosternal burning, epigastric pain, and volume reflux, also called as regurgitation. But really speaking, it's not regurgitation. Reflux or volume reflux is more typical, where patient will say acid comes in his throat when he goes to blood, things like that. It is a good idea if you want full 3 marks in this to also write the non-esophageal symptoms. It's very well known that patients with GERD also get cough attributed to GERD, laryngitis, throat pain, asthmatic attacks, aspiration. These are some of the extra esophageal or non-esophageal symptoms of GERD that you should be aware about. If you write this, you will get good marks. Then you come to investigations. Investigations is easy. You just write the ones which are important. So of course, the investigation will be endoscopy with, if required, biopsy. And on endoscopy, the grades should be written based on LA classification. So LA grades, you have grade A, B, C, D that you should write for. So as the disease will become more and more severe, it means the grades will be higher. And sometimes on endoscopy in GERD, you may see Barrett's esophagus, hiatus hernia. Then you write about what Barrett's will look like. You get those very typical tongue-like projections at GE junction. Right. So those tongue-like projections at GE junction, where if you take biopsy, you will see columnar metaplasia. And of course, the other investigation is 24-hour pH study. And this is usually going to be done if endoscopy is normal or if you are planning an anti-reflux surgery, like a Nissen fundoplication. So if you are planning a surgical procedure, so prior to that, you have to be sure that yes, he has GERD only and not anything that mimics GERD, or if he has extraesophageal symptoms. In that case, you will do a 24-hour pH study. If the score is more than 14.7, that means the symptoms are due to acid reflux. So if you write this much, it's more than enough. Last part is treatment. Whenever you write treatment, always divide the treatment wherever possible into medical, minimal surgical, and surgical. And obviously, the medical management of GERD is going to be PPIs, which will help in promoting the ulcer healing, right? So you stop the triggers, dietary changes, elevated head end of the bed, and PPIs. Do mention briefly about the minimal invasive procedures. They are there in Bailey, like radio frequency ablation of the mucosa or magnetic sphincter augmentation. This is important. It is also called as the name of the company which produces, or the name of the device. This is called as links. Okay, where they put some magnetic implants around the LES so that it becomes tight. Okay, that is called as links procedure. So these are some of the devices which are minimally invasive, not so commonly used in India yet. And of course, surgery. Whenever you write surgery, what are the indications? So if medical management fails, person has severe symptoms or he has volume reflux, a young patient who has volume reflux, you're not going to tell him take PPIs forever, right? Or if he has complications like hiatus hernia. Best example. In these patients, an anti-reflux surgery is advisable, and you are going to write about flopinison and toupee. So flopinison is going to be 360-degree, toupee is going to be 270-degree posterior. Right. So these are some of the procedures. If you divide your answer like this, it will look very good, and you will get almost full marks in a straightforward question like this. All right. Moving to the next one. Define and classify anorectal malformation. This is pediatric surgery. Briefly discuss the presentation of ARM and how will you manage anorectal agenesis in a newborn male child. So there are 4 parts to the question. First, they are asking you to define anorectal malformations. So it is a congenital problem because it's a malformation. There is a failure of development of the anus or the rectum or both. And because the anus is not formed properly, the anorectal area is atresia. Because of the atresia, the colon gets obstructed. So this will lead to intestinal obstruction. So straightforward definition. Now, what are the types? How will you classify ARM? What the books will give you are called as low anorectal malformations and high anorectal malformations. A low ARM is one where, if you look at it like this, so let's say this is the sigmoid colon, then you have the rectum, and below the rectum, below the levator ana is the anus, which opens into the anal verge. A low ARM, the atresia or the narrowing will be below the level of the levator ana, like maybe this much of the anus is formed, rest of the anus is not formed. So the malformation will be below the level of the levator ani, that is a low ARM, where the pelvic floor is normal. Best examples: imperforate anus, anal membrane, anal stenosis, and these are the common ones. Low ARMs, of course, are going to be common. Some of them don't even manifest in the initial period. High RM are usually more complex, where the malformation or the defect will be at a much higher level. So the malformation will be, let's say, at the level of the rectum, which means everything below here is going to be atretic. So these type of ARMs are going to be called as high ARMs, and in high ARMs you will get a rectal atresia. Some amount of rectum is not formed, and many times because the rectum is not opening into the anus, or the rectum and the anus is not formed, the proximal rectum will fistulate with some structure in front, depending on whether it's a boy or a girl. If it's a girl, then the structure in front is going to be the uterus, cervix, vagina. So in a girl, the rectum will have a fistula with the vestibule of the vagina. That is the most common ARM girls. So rectal atresia with rectovesical or rectovestibular fistula in girls. If it's a boy, in front will be bladder and urethra. So in a boy, he will have a fistula between the rectum and the bulbar urethra, rectobulbar fistula. These are the most common types of high fistula. Higher the malformation, more complex will be the fistulae. The worst kind is where there is a single opening in a girl child. The rectum, the uterus, and the bladder all have a single opening that is called as cloaca or persistent cloaca, where there is a single opening in a girl. So bladder opening, bladder urethra, uterine, and anorectum all open into a single path. Of course, this is a very complex malformation. That's the second, right? So this is how you will classify. Presentation and management is very simple. Obviously, it will be diagnosed at birth. The neonatologist, when the baby is born, he checks for some congenital malformations. This is something he should see that the anus is not opening. There may be a pit. So there should be failure of the child to pass meconium. There may be a pit at the site of anus. So where the anal canal should open, there is a pit of opening. Or if the baby was born somewhere not in a hospital where no pediatrician saw, maybe after a few days the mother will have to bring the child to the hospital because he will have an intestinal obstruction, colon will be blocked. He may have complications. So he may present with complications. How are you going to diagnose it? See, it's a clinical diagnosis. You don't need to do any test to identify ARM, but you want to know the level of occlusion or the level of malformation, for which a good way to begin is an X-ray invertogram. You must have seen this image. It's a very popular image where they show a baby either in lateral position or in prone position. X-ray is taken and they place a coin at the site of the expected anal opening. So you can make out how far the gas has gone, how far is the rectal gas, and how far it is away from the anal point or the radiopic marker. If the gap is too much, that means the ARM is a very high defect. The gap is very little, less than 2.5 centimeters. It's a low ARM. But of course, nowadays, to get the anatomy of the ARM and the fistula, you are going to do a CT abdopelvis. That would be the best way to go about it. So these are some of the tests you will do. And the treatment, of course, is going to be surgical reconstruction. For a low ARM, you can straight away do an anoplasty. High ARMs will require reconstructions, which is what has been given in the question. And many times in a high ARM, it is done in stages. You do a staged repair, where in the first stage, you just do a colostomy. Let the child become okay, let him grow up a bit. First do a colostomy, then you do the PSAR, posterior vaginal anorectoplasty. All right, not so difficult. One of the easier things to diagnose. Surgery is not very easy, but manageable. The problem is these children also have a lot of other abnormalities because ARMs are commonly seen in bacterial group of abnormalities. Vertebra, anorectal malformations, cardiac, tracheoesophageal fistula. So a lot of these kind of problems are seen. So that's how you will manage low and high ARMs in a staged manner if it's a high ARM.